Good afternoon. Welcome to our session on the impact of COVID on vulnerable populations and family planning. My name is Elizabeth Gummerson, and we have with us four panelists, Aditi Vyas, Maria Tsolka, Nargis Rakimova, and Tamar Homarsuridze. And I'm going to introduce each of them in a little bit more detail, but I first introduce myself. My name is Elizabeth Gummerson. I am the moderator of this session. My job is the executive director of the PMA project, which is a 9-country women's reproductive health survey. But the reason that I'm moderating this is not that. The reason that I'm moderating this particular session is because about a year ago, a colleague of mine, Dr. Celia Karp, and I were commissioned by the Gates Foundation to write an evidence review of the effect of a global evidence review of the effect of family planning, the effect of COVID on family planning. And we reviewed all of the evidence available at the time, and one of the things that we found is, on average, the women's family planning was more resilient than we expected it to be, or that we feared that it might be in the face of COVID-19. But one of the big findings of our review was that there was very, very little evidence available on the impact on vulnerable populations, and the evidence that was available was worrying. And so we have with us four speakers who have actually gathered that evidence, are going to kind of fill that hole for us, and I can't wait to hear what they have to say. So thank you all so much for joining us, and I think we'll start with Aditi Vyas. And I'm just going to give a quick introduction as you go get set up. So Aditi is a development sector professional. She has over 12 years experience in gender, adolescence, and empowerment and education. And her area of expertise includes program design, management, qualitative research, curriculum development, review communication. She works for ICRW, currently focused on the development of teachers' systems assessments tools as part of the Life Skills Collaborative program. And the other thing that she's doing is assessing the impact of COVID-19 policy response on informal women workers in Delhi's National Capital Region as part of the Rebuild project. So in that vein, she's going to share some of her research today that focuses on the pandemic and constrained access to sexual and reproductive health services for women in the informal economy in India. Thanks, Aditi.
Thank you so much, Elizabeth. Thank you, everybody, for joining us today here, and the ones who are joining us virtually. If there are any people who are watching, I hope you all had a nice lunch and are not, and I hope my presentation doesn't put you to sleep. On that note, as Elizabeth spoke about, evidence review and just really looking at what have been the COVID responses to the crisis, the pandemic crisis, and how has it impacted the vulnerable populations. The Rebuild project essentially looks at that. So my title of the presentation, as you can see, is The Pandemic and the Constrained Access to Sexual and Reproductive Health Services for Women in the Informal Economy in India. I'll just go next. Right. So the project itself looks at the policy responses and how has it impacted the informal women workers in the Indian urban economy. How are we defining these informal women workers? Just to give you a context, we are a country of 1.3 billion people. Within this large population, there's a sizable section of urban informal women workers who do not have access to social security benefits. 87% of them do not have any access to social security benefits. Over 80% have no access to job security in terms of having work permits, and most of them come from migrant backgrounds, so they're living in urban settlements and urban informal settlements. We wanted to understand how has the government response to COVID really impacted women's lives who are working in this space. So the project objectives really were to understand and identify key areas of vulnerability for informal women workers, specifically also looking at areas of vulnerability that are impacted in terms of their sexual and reproductive health, their mental well-being, economic precarity, if any, to assess the gendered impact of the policy responses. So when the pandemic hit, there was a lot which was being talked about and written about in terms of how there should be social protection measures for workers, but mostly migrant workers and mostly men. We wanted to understand what was this gendered impact for women informal workers, and how it really sort of made their lives easier or more difficult, also in the context of sexual and reproductive health services and overall mental health. We also wanted to understand the urban infrastructure and what are the things that really worked or did not work. What were the coping strategies of these women and how did they deal with this crisis? So with that brief context, I just want to sort of move ahead and talk about what was the methodology. We started this project about 2 years ago. We had an exploratory sequential mixed method design. We started with an evidence review in terms of looking at the literature, what are the reports that are coming out on COVID, and what are the policy responses when the pandemic started. Was the government talking about prioritizing sexual reproductive health or any other social policies that really impacted this particular section of women? So we did a scoping study which incorporated a literature review, policy review, macroeconomic review, and also a few KIIs with or key informant interviews with subject matter experts. We did a policy landscaping review of secondary literature and a caste, labor, and gender review. All these reports are available on the website. If you go to the ICFP website, we have a rebuild page, and you can access this literature there. So the caste, labor, and gender review, just to give you a quick overview, looked at the intersectionality of caste, labor, and gender, and how the interplay of these three aspects really impact the lives of particular informal women workers, specifically in the professions of sex work, bangle making, and sanitation workers. Because typically in India, sanitation workers come from lower castes which are in the social hierarchy and have even fewer social protection mechanisms. We also conducted a formative research study which comprised of online semi-structured survey and group discussions along with KIIs to sort of inform the primary research design. The primary research comprised of two different aspects. One was the quantitative survey. This was an in-person quantitative survey. It's important to note that it was an in-person survey simply because, with the opening up of everything, and the restrictions really easing, everybody was going back to work, including the domestic workers and street vendors. So while the survey was conducted online, it also had its limitations. People were busy. Online survey also has its own challenges when people have limited time and they can choose not to answer certain questions and not go in depth. And the qualitative study, we did in-depth interviews with 25 domestic workers and 25 street vendors. And these studies were concentrated in the area of Delhi and National Capital Region, which comprises the city of Noida, Gurgaon, and Ghaziabad. Gurgaon comes in Haryana, which is another state. So it was also interesting to look at the policy responses between the differences in policy responses between Delhi, which is the national capital, and other states which are part of the national capital region but not part of Delhi. So, in terms of they come in Haryana or Uttar Pradesh. So, this is the overview of the project in terms of what we have done so far, and moving on to the key findings. So when we looked at the policy landscape, what was the policy landscape really telling us? When COVID hit, government was issuing advisories for the lockdowns, what you can do, what you can't do. Including all of that, they also put out very strict advisories and recommendations which said that, focusing on sexual reproductive health should be a key focus. They should be part of the essential services, which means ensuring that women and in general population has access to reproductive services, maternal newborn child health services. However, despite several advisories and schemes issued by the state government and the central government, because we were grappling with the pandemic, there were two lockdowns, most of the health services were diverted to COVID care. This includes the frontline workers who are the mobile frontline workers, ASHA workers, who are supposed to create awareness and also be the last point of contact for urban centers and rural centers. Those were also diverted to COVID care. Certain initiatives, when the partial lockdown was lifted, they were resumed. So, for example, UP government put out an advisory that now there can be door-to-door delivery of condoms and contraceptive pills and overall information dissemination amongst different groups. However, all of this definitely led to increased economic precarity amongst these vulnerable group of women. They experienced job loss and employment due to lockdown. I mean, we all know this, and I have experienced this myself. The moment the lockdown hit, domestic work was shut down. Street vendors could not go out. A lot of people switched to online methods of transaction. But the women, did they really actually, were they able to do that? Not necessarily. Informal women workers experience food shortage due to loss of income. We know that women tend to sort of reduce their nutrition every time economic precarity hits so that they can ensure that their children are eating well and the rest of the family is eating well. A lot of them did not have access to relevant social security documents, which further hindered their access to food security measures like ration that the government was giving out as part of the COVID response. There was an increase in unpaid domestic and care work and declining mental health and an experience of violence within and outside the household. When I say within the household, it is spousal violence, it's domestic violence, and when I say outside the household, I'm referring to when street vendors or domestic workers wanted to go out and access work. They experienced violence or threat of harassment from the police, from the local bodies like the municipal corporation. And overall, there was a difficulty in accessing relevant sexual health reproductive services, increase in unplanned pregnancies, restricted access to condoms and contraceptives, and overall, just even menstrual products. Like, none of these things were a priority at the time. Um, in terms of, sorry, in terms of our primary research findings, I'm talking about the survey and the qualitative research here. So when we look at the socio-demographic profile or our informal women workers, the domestic workers and street vendors, uh, most of them are married. 81% are married. And it's interesting to note that 52% and 31% are actually sole wage earners and chief wage earners. I mean, all of these women are working. They are domestic workers or street vendors. But it is interesting to know that a seizable amount, the majority are chief wage earners, and one third are about sole wage earners. However, about almost 50%, 49.1% have no schooling. 30% do not use mobile phones. This is a very important point to note because a lot of the work in terms of for street vendors especially, the entire economy focus shifted during the pandemic. The government and overall private sector was promoting use of online payment getaways, which women who did not have mobile phones, either the technology or the knowledge to access it, could not avail these services. And we have the data, 30% did not use mobile phones. And it is also interesting to know that in this entire section of domestic workers and street vendors, when the survey was done with 1,502 women, majority belong to a marginalized caste groups. So you can see only 21.17% are from the general category, and the remaining belong to the scheduled caste, scheduled tribes, and other backward class caste categories. In India, that is like the bottom of the social hierarchy. This is the demographic profile. Moving on, when we talk about access to government documents, while majority have Aadhaar card is a basic identity document in India that is mandatory and it links you to various services that you can access. However, 44% had no ration card, and ration card is a requirement for you to be able to access the public distribution system. So where you're getting access to free food grains to a certain amount every month. 44% did not have this access. When we talk about street vendors, it's interesting to know that while 81.5% of women manage the carts or the stalls for street vending, only 51% have the cart registered in their name. Others have card registered in the name of their husbands or their sons or other people, and only 30% have a certificate for street vending. It's also important to note that amongst these two categories of women, domestic workers and street vendors, government has a policy for the street vendors. There's something called the Swanidhi scheme, which accords people who, like women and men who are in the profession of street vending, to access loan to register the cart in their name. But I mean, the registration in itself for women street vendors is fairly low. When it comes to decision making, it's so interesting to note that almost 70% of women who are either chief wage earners or sole earners are taking on an average of 5 to 6 decisions on a daily basis. And when we talk about decision making, this comes from the point of view where they're talking about household decisions, what to buy, what not to buy, where will the money go, what should we spend it on? Should we spend it on health services? For whom? Children's education, prioritizing their own work, domestic care work, traveling to go see someone, what kind of clothes do they wear in the household. All these factors because become very relevant for our cultural context, because we know that women are not typically seen as decision makers in the Indian cultural context where social norms prevail and patriarchy is rampant. However, while 70% of chief wage earners and sole wage earners do make decisions, they also are at the risk of facing backlash from the husband or the family members. We also noticed that there was reduced decision making. 3 more minutes. Okay, I'm so sorry. There is reduced decision making amongst those who are neither chief wage earners nor sole wage earners. Very quickly, as I've been reminding you of the remaining time. Okay, so I'm going to just run through this. You guys can see the statistics on the screen. Economic precarity impacted every aspect of the lives of informal women workers in the Indian urban economy, which meant that they experienced job loss, they had to borrow money, and this is the borrowing is not from formal sources, from really informal money lending kind of bodies where they have to pay higher rate of interest. Formal borrowing is only 6%, as you can see. So all of this really impacted other areas of their lives, which meant for when we talk about sexual and reproductive health services, um, women tend to see sexual and reproductive health services only in the respect of pregnancy, childbirth, delivery, postnatal, prenatal care. Family planning doesn't really come up as much, and neither does menstrual hygiene. So when we spoke to the women during the in-depth interviews, there were instances of them narrating the kind of treatment and care discrimination they faced at government institutions, the fact that they had no money because all the money had gone into managing expenses during the lockdowns, loss of employment, which meant that they couldn't access government hospitals because of COVID and had to go to private hospitals, which also meant borrowing money to be able to meet pregnancy and related costs. We have some quotes here. One of them spoke about how when she went to a government hospital when she was pregnant, she had to share a bed, and the service providers were just really not paying attention. They were quite rude, and they made comments about how she has loss of blood and she will die and her child will die. So because of this experience, she had to move to a private care afterwards, the quote in the middle, and for which she had to really shell out money and borrow money to meet expenses for her care during pregnancy. So, like I said, economic precarity very clearly and severely impacted women's access and addressal of SRH needs, which meant that loss of income and savings really resulted in women borrowing money to meet extreme expenses. When I say extreme, I mean like when they were really in crisis and they had to deliver a baby or they had complications during pregnancy. This also meant that because of limited economic resources, the postpartum care seeking also reduced, and the fact that all the care workers were diverted towards COVID relief, they really didn't have access to ASHA workers who could have probably given them information or even other resources like contraceptives and iodine pills and other things that government usually recommends. Um, Also, just to sort of reiterate, I know I have like 1 minute maybe, yeah. Um, we in general, we know that women's health tends to be deprioritized, especially for marginalized, vulnerable groups. And for these groups of informal women workers in the Indian economy, health and within that, sexual and reproductive health is further down the bottom of the layer of priorities. They prioritize other needs in terms of their own household expenses, the health of their children, the overall household running, as opposed to their own health. They don't talk about SRH in terms of menstrual hygiene or family planning, but mostly limited to pregnancy and pregnancy care. And in terms of family planning, they tend to talk about how they don't need family planning methods or use of contraceptives because there was mixed response in terms of using partial contraceptives. Sometimes they could access condoms from the government facilities, but they also spoke about the poor quality of condoms. Or they also spoke about the fact that when they were using birth control pills, it had negative side effects on their health. So we had a mixed response here. And the older women talk about how they are sterilized, so they don't need family planning methods or use of contraceptives. In terms of menstrual hygiene, we also had stories of women saying they used cloth because they couldn't afford to buy sanitary napkins. The ones who were using sanitary napkins, interestingly, were using the ones their daughters were receiving from schools as free of cost. So that was an interesting finding. And I know I have no time. Just in terms of way forward, what does this data mean? What do these studies that we do with vulnerable populations and looking at the impact of COVID on policy responses and its impact on SRH mean for us as a group, as a community, for policy recommendations? First and foremost, it's very important to use these studies and leverage the data for policy advocacy amongst relevant stakeholders, which means the government, the local health bodies, the other stakeholders that work with these population groups. It's also really, very crucial to utilize the local health channels to ensure that women have both the knowledge and the access to care. It's not just enough to just give out condoms or give out, contraceptive pills without actually educating them on the importance of the same. Because there's a perception that some will cause health problems, or the condoms are of not a good quality. Similarly, it is very important to sensitize the service providers, both at the government and private level, where they treat women from these marginalized groups with the basic level of respect and care as they should. And lastly, capacity building for greater involvement of urban local bodies, which means municipal health corporations and other organizations that can actually improve the experience of women when they're trying to access care. In terms of programmatic inputs, overall, just ensuring and designing programs that adhere to the multiple levels of marginalization that women face and come from, and just ensuring that those needs are actually catered to and adhered to. Thank you so much for your time. I'm sorry if I took more time than required. Thank you.
Thank you, Aditi. So our next speaker is Maria Tsolka. She's from Save the Children, and she comes originally from a clinical nursing background, educational background. She started her humanitarian aid work back in 2005 with an emergency response in Iran following an earthquake, and has since worked in Sri Lanka, Uganda, Sierra Leone, Haiti, Lebanon, and the DRC, among others. She works mainly with maternal and newborn sexual and reproductive health in humanitarian settings. And she's the co-leader of the IAWG Adolescent Sexual Reproductive Health and Emergencies Global Working Group. And she's going to present to us today on some work that she has done with her colleagues at Save the Children on understanding the sexual and reproductive health experiences of refugee and host communities. Refugee and host community adolescents and youth during COVID-19. So needs, barriers, and opportunities. Thank you very much, Maria Tsolka.
Wow, that sounded like a long list I've been hearing. Thank you. First of all, I want to acknowledge the people that actually were really involved in this research. I was just a general oversight. So I really want to acknowledge Katie Meyers, who really worked hard together with our team in Rwanda, and most of all the adolescents that contributed in this research. So the vulnerable group we're looking at from our side is really adolescents in the Mahama camp in Rwanda, mostly Burundian refugees, and also the host community. So I'll give you a general overview, and I really want to focus a little bit on the methodology because it has been an interesting one, but also on the recommendations and the actual stories of the adolescents. So what's interesting about this study is that we really we tested a new tool, a new methodology that we were not really that much. We didn't know a lot about it, so we tested and piloted a new research tool that really helped us in this process. The background, as I said, was to document mainly how the COVID-19 pandemic has affected access and utilization of SRH services among adolescents and youth living in Mahama refugee camp and the surrounding areas. The target group was ages 10 to 19 and youth ages 15 to 24. Kirehe district is the district that is bordering Tanzania from the Rwanda side, and this happened back in 2020. So I also want to acknowledge the Ministry of Foreign Affairs of the Netherlands that funded this, but also the Interagency Working Group, as I said, that we co-lead, and anybody who's interested to join is very welcome. Please find me at the end. Our hypothesis, I think, is something that we all know, that SRH information and services delivered during COVID-19 were not meeting the needs of adolescents and youth in the camp. We thought about this, we ended up like having this hypothesis because this is the reality of many of the adolescents in many other populations, so we thought like it's not going to be any different like for this population, specifically in the camp. I want to stop here a little bit on the SenseMaker approach that we use to collect data, and I will use like the way it's described on their website. It's a company called Cognitive Edge, and like they describe it as you enter a gallery, an art gallery with pictures and like paintings, and instead of actually having like a brochure or like the information that gives you like that you get from the painting that is very specific, you actually have the painter themselves in every painting describing for you and asking you, talking you about the process, how they ended up with these methods, like everything you want to think as a storytelling approach. So this was the interesting part about this methodology. We used tablets to do it. The tool really asked respondents to answer a prompt and then request them to answer specific questions about the response they just shared using modulators. Modulators is not a term that you should know. It's really very specific to the actual like SenseMaker application, and it's really it's when the participants ask the question, they responded to the question. They use different themes to describe their experience. So we use like different concepts and words designed to reflect potential modulators of their stories shared. And we're going to explain you a little bit more about this and show you exactly what they were seeing at their, on the screen of the tablet. So going to the methodology, as I said, this is like actually what like the respondents would look at. The prompt is what you can read if you have needed to seek help with your health since COVID-19 has started. Please describe something from this experience which stands out for you. You can continue reading. This is the only prompt we gave, and based on their responses, then we would like provide like what we call the modulators. Here we have the example of like what could have made things better in my story, that all dependent on the story they were actually telling. So the process to do this, before going to that, was not an easy one. I mean, like there was a lot of like pre-work in order to create these themes and ensure that like they are linked to some of the stories as they happen. The study information, more in detail here. I only want to stand a little bit on like how many stories we collected. We collected exactly 745 entries we had of stories. From these 745 entries, we ended up really analyzing 517. The reason for this was we had some duplicates, we had some mistakes or like missing parts, etc. We also, something very important, we chose to target adolescent girls in higher numbers as they are more affected by access constraints to SRH services, as we know. So let me focus a little bit on the key findings. So as I said, to analyze the transcripts from SenseMaker, we also, something I did not mention, we also, after the analysis, did a focus group discussion to validate the responses and ensure that we are on the right direction. And the focus group discussion included like adolescent girls, adolescent boys group, but also health facility providers and community mobilizers. So these are the four themes, actually, three actual like emerging themes from the analysis: the enablers, the barriers and obstacles, and opportunities. Whoever wants to know more about the analysis and the coding and all these like very technical things, so they can find me, but I don't want to spend like too much time on this myself. So here is it, an example. So here's a quote from one of the stories. The stories were quite long, and it was difficult to read from what my colleague mentioned. So based on this quote, for example, and which come from a story, it's categorized on the enablers, and the enablers describe the factors that allowed for adolescent and youth to receive the health services they wanted and needed. At health facility level, the most important enabler, which is important to keep in our mind, is that they stated they trusted health staff. So it's not new information, but like it's very important to know that it's coming from the adolescents themselves. Outside the facility, they also mention like youth programs, including community mobilization activities that persisted during the pandemic. They also mentioned the assets that contributed to positive outcomes. For example, they described how having goals, a supportive family and peer network and employment enabled them to make healthy decisions for their lives. On the barriers and obstacles, on the emerging things, we really some of the barriers actually and obstacles they were mentioned is like the changes due to the COVID-19 and how they impacted the actual like access to health services. Also the inadequate health facility services in general. They also, another like a barrier and obstacle that was mentioned, it was the disruption to social support systems and services. For example, discontinuation of school or education sessions, and a lack of youth programs or activities due to the reduced hours of staffing from NGOs. A fourth one was perceptions of social norms and stigma surrounding SRH. And I want to really like highlight that they talked about the social pressures they faced if they had premarital sex, calling themselves failures, or saying they had failed to abstain. Many adolescents and youth cited religious reasons or family pressure for wanting or trying to avoid having sex before marriage. And on the opportunities, youth integrated and tailored programs, dedicated youth staff, so people they really have faces that the adolescents know, and bolster social support systems and services. Here are some of the key results, and I don't want to read them. I don't feel that for people working like in the adolescent sexual reproductive health, it's something new, but definitely like we would like to highlight like how the less time in formal and informal education spaces affected like this anxiety and like increased likelihood of sexual behavior. From the health facility side, and in general, like highlighting how overlapping crises affect the provision of health services and other humanitarian services and programs, especially for adolescents and youth. So what about recommendation and next steps? Our research really contributed in the knowledge that that was there, but then at the same time, we are lacking like a lot of analysis and like very like formal like research to provide these answers. So reading it, like you might not see that there's something new, but the lack of this information during humanitarian setting and for this particular population is very important. So this research just like reinforces the message as much as possible. So please use it or come and find us if you want to cite it and use it. And some of the recommendations that come, I want to remind that all of these recommendations come from the adolescents themselves. So it's not something we translated. These are their stories that we themed, and like we provide some guidance to how to go and validate it with a focus group discussion, but they are really coming from their side. So practitioners should examine how triage categories are created and ensure that access to emergency contraception, pregnancy testing, and treatment for STIs is prioritized for all patients, including adolescent and youth. The practitioner, and by practitioners, I'm not talking only about health practitioners, but also anybody involved in ASRH programming, to ensure that the youth coordinators, or what it's called, or another like a modality that is used in Rwanda, the father educators are on hand to support adolescent and youth in getting access to the appropriate services. Understanding also how crises affect households themselves, and ensure that, you know, when you're providing like a guidance to clean your hands, for example, ensure that you're providing the adequate like materials for this, like soap. So definitely like ensuring that you're like coupling like the non-food items, like the distribution, with the health services and integrate them. And in terms of general recommendations, like we have a long list, and I can provide like a lot of more details on each one of them. But I think like I will stop here, and I want to really say that one of the things is like training for ASRH is very important, especially for humanitarian settings. There is an amazing like training package that was developed from Interagency Working Group for Reproductive Health in Emergencies, and it has already been like done like as a TOT in many regions. So please like reach to us to be part of it. It's an open source like training package, so you have all access to it, and training like to ensure that the you know, diminishing like the bias, especially of the providers and whoever is getting close to adolescents, are receiving appropriate information. So with that in mind, thank you very much, and thank you.
Thank you so much. All right. Our next speaker is Dr. Nargis Rakimova. Dr. Rakimova is a trained pediatrician. She has a master's degree in reproductive health and a doctorate in public health. So an MD, master's, PhD, doctor. During almost 25 years of her professional experience in the social and international development sectors, she's worked on different projects for UNFPA, WHO, Asian Development Bank, and the Ministry of Health. She has more than 15 years experience with UNFPA and is currently the head of UNFPA office in Tajikistan. And today she's going to share some of those experiences with a presentation on ensuring access to quality sexual and reproductive health and family planning, and basic psychosocial support services from referrals for people with disabilities during the COVID-19 pandemic in Tajikistan. Thank you, Dr. Rakimova.
Thank you very much, dear Elizabeth. Good afternoon, dear colleagues, partners, guests. Allow me please to introduce brief presentation on ensuring access to sexual reproductive health, family planning, psychosocial support services in the context of pandemic in Tajikistan. Taking this opportunity, we would like to express our deep gratitude to organizers of this high-level conference for considering our abstract and for the invitation. The main authors of this project couldn't come for good reasons, and I was given the opportunity to introduce this brief presentation on behalf of our team, which consists of Minister of Health and our staff, as a co-author, who is also took part in implementation of this project in Tajikistan. Here, we present as one of example experience in addressing SDGs leaving no one behind approach. In the first two slides, I would like to give brief information about the country context. Tajikistan is located in Central Asia, bordering with Kyrgyzstan, Uzbekistan, China, and Afghanistan. So according to the, and it has its own landscape characteristics. That is 93% territory is mountainous. According to the preliminary results of the Population and Housing Census 2020, The total population is 9.6 million, but this year, the population reached 10 million. Of the 60% of them are young people under the age of 30. Annual population growth is 2.2, which is highest in Central Asia. Despite the progress in the poverty reduction, 26% of the population is still living below the poverty line, mostly in rural areas. Government reports that 1.6% of total population are disabled people, and 2/3 of them are women, children, and girls. Although the government approved or recognized UN Convention on the rights of persons with disability in 2018, but it is not ratified yet. Aiming at this, the National Action Plan was approved for the preparation of Tajikistan for ratification and implementation of UN Convention. Along with this, government approved a number of strategic documents where disability issues are prioritized. In this slide, you can see the name of these strategies. In the next slide, I would like to talk a little about the situation during the COVID. Country officially reported the first COVID cases in very later stages in 2020, while numerous cases of illness and deaths already noted among the population. Despite adoption of urgent epidemiological and lockdown measures to contain the virus spread, the COVID pandemic has exacerbated inequalities, exposing the extent of social exclusion and neglecting inclusion efforts, disability inclusion efforts. The pandemic has primarily affected people with disabilities. Further, I will call it as a PVD. Due to the local economic downturn and lockdown measures, small livelihood programs targeting disabled people were closed in that time, leaving them without basic sources of income, with great difficulty in accessing basic health care, purchasing necessities, and other essential expenses. The pandemic and its associated restrictions made them even more vulnerable to sexual and gender-based violence, with much more higher risk of domestic violence. As many as 158,000 estimated PVDs become one of the most marginalized groups in Tajik society during COVID crisis, including in terms of morbidities associated with lack of services. In this regard, UNFP has focused on the continuity of SRH services in line with its COVID response plan, with particular attention to women and girls with disability. In the next slide, let me please to highlight a few words about the program intervention. The main goal of the project intervention was to build an access to preventive, promotive, and curative SRH and psychosocial services in order to reduce the risk and morbidity and mortality among disabled women and girls. With that purpose, we closely worked, the UNFPA country office closely worked with the Ministry of Health and Social Protection and also Association of National Association People with Disabilities and CSOs. Methodology. The project was designed based on UNFPA WHO guidelines for providing rights-based and gender-responsive services. A memorandum was signed between the UNFPA, MOH, National Association, and CSOs. With technical assistance of UNFPA, the Ministry of Health established 5 centers for disabled persons within reproductive health centers, which was supported from the state budget and staffed by Ministry of Health. National experts reviewed existing policies and practices, and for the first time developed new national standard operating procedures to provide quality services to disabled people, particularly on SRH, family planning, and psychosocial services. This SOP integrated inclusive culture, quality of care, data reporting and referral system. Further, national service providers were trained on this SOP and to provide quality services to this category of population. Project results. Over 800 people with disabilities received face-to-face family planning, SRH, GBV services at the newly established 5 these medical centers or cabinets of the country. More than 1,000 PVDs, or people with disabilities being homebound and with mobility problems received services at home. And they were provided with the adapted dignity kits and PPEs. Critical team of national experts established and enabled to implement this project and SOP across the country. Government, development partners, CSOs highly commended this project and recommended its nationwide adoption. This project has been scaled up as a disability inclusive innovation in UN system, resulting in creation of the such system in the country. UNFPA and further 5 more medical cabinets or centers were established in other regions with introduced voucher-based awareness raising system. This was also innovative approach. UNFPA Innovation Fund supported scale up of the intervention that resulted in new partnership with CSOs, with NGOs, who is working with people with disability for better awareness and increased visits of the disabled people to these centers. Institutionalization of these centers financed from the state budget put sustainability to a model project. Currently, according to the recent data we have received, the number of visits has been increased threefold, and of which 95% being women and young girls living with disabilities. Internal cooperation between narrow specialists increased, and to provide a wide range of health services and increased referral system. During this cooperation, number of health matters were addressed, including prevention of cervical cancer. Among them, we were found out the pre-cancer diseases. So they were referred to the neuro specialists and they received the relevant treatment services. In the next slide, you can see pictures from real situation that were agreed with them, and also you can see the standard operation procedure that was approved by the Ministry of Health order. Project implications and lessons learned. The main implication is in this project was to address the near total lack of essential life-saving and rights-based SRH services for people with disabilities by mobilizing new knowledge and expertise during the COVID pandemic. Secondly, this practice was successful as it was in line with internationally recognized standards, guidelines of WHO and UNFPA, also in line with national context and national strategies. Thirdly, disabled people have started to participate as an agent in planning and implementation of their health care. Fourthly, partnership in different levels is very important in introduction of any activities addressing leaving no one behind. Finally, gratifying to note that government made decision to expand this practice and integrate this in developing Tajikistan's new ratification document, which is on the way. Thank you for your time and attention.
Thank you. All right, our final speaker today is Dr. Tamar Khomasuridze. Dr. Khomasuridze is a clinician and also holds a doctorate in reproductive health, so another doctor. She has more than 30 years experience in the area of sexual and reproductive health as a doctor, a researcher, and a consultant. She's also with the UNFPA. She's been with the UNFPA since 1999 and is the head of the UNFPA country office in Georgia, as well as the Sexual and Reproductive Health Regional Advisor for Eastern Europe and Central Asia. And in that role, she has a front seat view on the impact of COVID in the region and is going to speak to us today on the impact of COVID-19 on sexual and reproductive health in 8 countries in Eastern Europe and Central Asia. Thank you.
Thank you very much, Madam Chairman. Dear colleagues, I'm honored to present today the impact of COVID-19 on sexual reproductive health in Eastern Europe and Central Asia on behalf of a team of authors who worked together from the very beginning of the survey, who worked on development of the report and abstract. I'm pleased to welcome Professor Mikkelsen, who is attending the session today. Actually, this report is the result of 2 important studies we conducted in the countries of Eastern Europe and Central Asia. First study was conducted in collaboration with Ghent University and ICFP Consortium, and this study assessed the impact of COVID-19 on general population. Parallel, but the interlinked study was focused on impact of COVID-19 on vulnerable groups. Before I start my presentation, I'd like to mention a couple of words about our organization and our partners. UNFPA is the United Nations Sexual and Reproductive Health Agency. We support countries to deliver the universal access to sexual and reproductive health as part of the Sustainable Development Agenda. And there are 3 transformative goals we set: ending unmet need for family planning, ending preventable maternal deaths, and ending GBV and harmful practices. And we are not alone. Of course, we implement our programs together with our partners. And Ghent University, which is hosting ANSWER, the academic network for sexual and reproductive health policy, is one of our main partners. So we work together in different areas to make sure that our joint support and assistance to countries we cover is effective and efficient. Our regional office, which is based in Istanbul, covers 17 countries of Eastern Europe and Central Asia to achieve these goals. Why this study was initiated during uneasy times, challenging times of COVID? First of all, some background about the situation. Of course, there were some expectations that the COVID-19 pandemic would affect both supply and demand side of SRH services. There were relatively limited evidence from the population side, the demand side, while the supply side was somehow analyzed at different levels, country level, regional level, by different organizations. But there was very limited knowledge about the impact on the most vulnerable. So the idea was to conduct one big component of the survey to assess the impact of the COVID on general population and to compare with impact of COVID on vulnerable groups. Another important issue why this study was very important for our region. As you know, Eastern Europe and Central Asia, this is the region where the health pandemics are not common, which means that COVID pandemic was, of course, very unexpected and unusual for our region as well as for entire world. But we wanted to get the evidences about the needs of population, in particular most vulnerable, to apply these evidences to our policies and to our programs. And most importantly, to integrate these evidences in contingency and preparedness plans which UNFPA supports countries to deliver. So we hope that the lessons learned during the pandemic and the outcomes of these surveys will apply and will apply to the policies and will help many, many people. During from the very beginning of pandemics, we were getting the information and news about pregnant women not being able to reach health facilities for safe delivery. There were some evidences demonstrating that the sexual reproductive health, and in particular family planning services, were closed due to shortage of the staff or due to COVID measures. And even Secretary General warned us about potential increase in intimate partner violence during the pandemic. So this is how we started our program, which was focused on two parallel but interlinked studies, as I mentioned. The first study, which was focused on 8 countries from Eastern Europe and Central Asia, it was part of the iShare international study, which was conducted in 30 countries. And we worked together with our partners, ANSO, to tailor the questionnaire instrument and methodology to the needs of the region and particular countries. The focus was general population, women and men of reproductive age, and the topics included wide aspects of reproductive health, including contraception and sexual health. The partners, it was iShare Consortium, and it was ANSWER, which was our main partner in this program. Another component, Leaving No One Behind, we call it, this was focused on entire region of Eastern Europe and Central Asia, and it was focused on most vulnerable women. In particular, we focused the study on 3 vulnerable groups: women living with HIV, women living with disabilities, and survivors of intimate partner violence. The focus of the survey was contraception, access to family planning, and here we worked with East European Institute for Reproductive Health and 2 regional and national networks, EVNA and ENIL, which provide support to women living with HIV and women with disabilities. 2 important issues. These both surveys were kind of revolutionary for our region and for our organization, because these were the first region-wide digital surveys. And we piloted and applied this methodology with engagement of our regional partners and engagement of our regional networks. The links to the survey, which was created by iShare Consortium, was shared for general component was shared by 8 UNFPA country offices to their national partners. And actually, this is how we rolled out the survey link. As for the Leaving No One Behind component, our regional networks working with vulnerable groups helped us through their national affiliations to disseminate the link. Talking about methodologies, of course, we recognize some limitations, first of all related with sampling method, also small sample for some of the countries, and some recall bias. And we recognize that this study and the sample is not representative for particular countries, sample size, we nevertheless acknowledge that the study was the only important, reliable source to adjust our support and to make policy decisions, to help countries to make policy decisions based on these studies. So in total, the iShare general survey, it covered more than 3,900 respondents, and the LNOB the number of people engaged in LNOB was close to 1,200. And now I want to underline some of the results. If you wish to get more information about methodology, about details, the report is already available on UNFPA website for Eastern Europe and Central Asia. Please visit the website. You will see many important facts and information there in addition to the study. 2 main outcomes, what we found when we are talking about family planning services. Most family planning services saw decrease in use during pandemic in all countries, and it was key evidence in both studies. However, the use of community services by LNB respondents did not significantly decrease during the pandemic. So I think this was one of the key lessons learned for us to apply for our future programs. One of the key questions we integrated in the questionnaire was, what are the reasons why the women choose the service? As you see in the questions, in the answers, the main and most leading, most common answer is where I usually go. And there is not we do not see big difference between general population and LNOB components, which means that there is some trust to the services, and the clients who have positive experience they had before towards the services, they continue to work and to attend the services. At least they're trying to reach those services. Second most important was method I want. So availability of the method of the choice is the second key factor. And of course, proximity from the living space or geographic condition is number 3. So I do not want to take more time about the results. Another and most important issue. One of the key questions we raised was about did COVID-19 stop or hinder you from seeking contraceptives? And here on this slide you see the respondents. The responses of our respondents from 2 groups. First column shows the responses from general population, and we see that the impact of COVID-19 in general population, it's a bit more than 4%, while in 3 vulnerable groups, women living with HIV, women living with disabilities, and women, the survivors of intimate partner violence, the data is more than 16.7, 80%, and 15.4%. And I think this is one of the key findings we have in this study, because if we are talking about effective responses during crisis, we definitely need to consider these evidences in the preparedness process. Sometimes when the crisis hits, we cannot provide immediate response. And next, these are results we received about barriers in accessing contraceptives during COVID-19 pandemic. As you see, transportation and movement restrictions were key for both groups, but mostly it affected the women in the group, in the LNOB group, most vulnerable women. Another important fact was that women were afraid to get infected while attending the services, and here you see that this affected vulnerable groups more than general population. Third result, I'm not able to or allowed to leave the house. As you see, there is big difference between general population and vulnerable groups. And one of the important issues, I can no longer afford it. So affordability is one of the main issues. And by the way, it's very important that general population is more affected by these barriers than vulnerable groups. Here the only explanation we have here is that in some countries, vulnerable groups like women living with disabilities or women living with HIV, they are better supported by some social and health programs compared to general population. This is one of the hypotheses I would like to provide. About barriers in accessing family planning during COVID-19 for vulnerable groups. As you see, what is common for all 3 groups, this is, I'm sorry, the legend for green color is not seen here. Here, the affordability of contraceptives is something very important and which is common for all 3 groups. Women who experience the intimate partner violence, women with HIV, and women with disabilities. Second most important issue is geographic accessibility and administrative accommodation. On this slide, we wanted to reflect the quotes from women from Armenia and Ukraine. And by the way, these were the countries where, in addition to LNOB quantitative survey, we conducted the qualitative survey. And as you see, the woman who experienced the intimate partner violence is referring to the cost of services, not only contraceptives, but also some tests and facility level services, and she's saying that it's not affordable anymore for her. Another quote comes from the person, from women with disabilities, and she is saying that, and this quote refers to social norms and attitudes. Women with disabilities are considered as angels, or the ones who do not or should not have sexual life and sexual experiences. And I believe these quotes are very, and we collected many quotes, which you can see in the report. So, key recommendations we want to deliver today for your attention, and recommendations which we share to all countries, regardless of the fact whether they're engaged in this survey or not. We face the same, more or less the same situation in all countries. First of all, we should actively target vulnerable groups to ensure their access and use of contraceptives during pandemic or beyond pandemic times. Removing the financial barriers to contraceptive services for the most vulnerable. I think this is also important issue and recommendation, which refers to times of crisis, but it's very important before or after crisis as well. Third important recommendation is about comprehensive information about contraceptives, to deliver this information in accessible and acceptable ways, especially if we are talking about women with disabilities. Depending on type of disability, this information should be accessible and acceptable for each woman. I think one of the key recommendations we delivered is promotion of telemedicine on family planning services, which worked in many countries, and actually I mean this recommendation helped many countries to accelerate these processes already. And another recommendation is about promotion of personal contacts with health service professionals. As you know, in our countries, the health systems are in the process of reforming, but sometimes in these reforming processes, we see that the contacts of client and service provider at primary health care level is not as close as we would like to see. And in the countries where these contacts are maintained, the impact of COVID-19 was much lower than in the countries where these contacts do not exist. Supporting community health services, as I mentioned, community level services were not affected by COVID-19 pandemic, and I believe this is one of the key recommendations we want to provide to the countries. And last but not least, our key and most important recommendation is to consider the lessons learned during COVID-19 pandemic in the process of development of preparedness plans at the country and regional levels. From our side, we fully recognize the importance of outcomes of these two surveys, and we advocate being engaged in policy dialogue at the country and regional level for implementation of these recommendations, integration of these recommendations in the policies in the countries of Eastern Europe and Central Asia. Thank you very much.
So thank you very much to all of our speakers. I wanted to pull out a couple of themes that jumped out to me in those talks. I think one of them was the link between the sort of economic downturn and economic vulnerability sort of exacerbating pre-existing vulnerabilities. And another was, the importance of having, focused services and focused interventions for these particularly vulnerable populations. And then another thing that I took from that is, even if you have these services in place, how important trust is between the populations and the people providing services. Having knowledgeable and trusted providers seems to be a really important element that came out in a couple of the talks. So it was really fascinating, and thank you all very much. We have a couple of minutes for questions if anyone has questions or comments or would like elaboration on any of the points. No? Silence? No, you can. You have 11 minutes left. Well, I'll go ahead and ask a question, and I think I really enjoyed these presentations because they were kind of a mix of just talking about challenges, but also talking about resilience and talking about the things that worked well. And so I wanted to ask each of you, and I'll give you a choice between two questions. But one was, in the work that you were doing, were there examples of resilience that surprised you or that you took a lesson from that you would share with implementers or people who work in the field that you think is worth paying attention to? Because that's always a kind of interesting part of research, is the things that surprise you. So that's one question. And then if nothing comes to mind, the second question is, and some of you said this in your comments already, but what is the key recommendation or key learning that you would want people to walk away from this with, just if you had to pick one? You can choose either one or answer a totally different question if you like, but.
I think
Okay.
key recommendation for us is to share the experiences in different countries, the experiences and lessons learned by different organizations, to make sure that we create some knowledge and we create a database of experience and lessons learned to be considered. Okay, we have much better situation in terms of COVID, but there are different challenges we are facing, and I believe that these experiences, if they are timely shared and if they are timely incorporated in the national, regional, and global policies and plans, I think we can significantly reduce the risks related not only to COVID pandemic, but also climate change and conflicts. Thank you.
Thank you.
Yeah, from my side, speaking from the adolescent voices, one recommendation, I think it's mainly about listening to their voices. I think it's very important that we actually listen to people and vulnerable groups particularly, in order to be able to provide the services they need the way they need it. So I think that's an important thing, raising our voices and then strengthening the application and implementation of whatever we have on our hands.
Thank you.
From my point of view, I would just like to say that the people that we were sort of working with, informal women workers and street vendors and domestic workers, I think for this vulnerable group of women, they are sole wage earners and chief wage earners in their households, but they are not able to prioritize their own health, and definitely not SRH unless and until they are pregnant or need emergency care. And one of the reasons for that is the distrust that they have in the government services. I mean, we also have stories from the qualitative research where women say that, we would much rather go to the traditional birth attendant or the dai, as we call it in India, as opposed to going to the hospitals and being looked after the nurses, because they're not treated well. There's this level of social stigma even before COVID, that you come from a socially and economically marginalized group, and therefore you are not necessarily treated with basic level of dignity. So really training the service providers to be able to give out the same level of care that you would to somebody who's a paying customer, so to speak. And the other part of it, recommendation I would sort of re-emphasize would be to ensure that the women in these vulnerable groups have the correct knowledge and awareness that, you know, not all contraceptives are bad. Just taking a birth control pill will not have effects, like ill effects on your health. I saw a meme poster in the exhibition room, which was really funny because it says, I thought that, you know, taking the birth control pill will have side effects, but I did not know not taking would have the biggest side effect of being pregnant, right? So just really educating all groups, not just the most vulnerable, but actually all groups, about what is available, what does it do, just that. Thank you.
Thank you. Since our practice related to the establishing and increased services by disabled people during pandemic period, my main recommendation will be that it's very important in promoting any initiative, any innovative approach, strategic partnership, and working with the existing stakeholders. The another recommendation is rely on evidence-based approaches, evidence-based strategies, because if we consider our practice, by that time, Ministry of Health didn't prioritize disabled people because they were, you know, in very difficult situation and they couldn't manage this situation. That it was very important for us that using these evidence-based approaches, we prepared the clear message, clear advocacy, evidence-based advocacy practices that helped us to come all together and promote this initiative. Therefore, strategic partnership, intersectoral approach, and relying to international standards, evidence-based approach is very important in improving to access to SRH and FP services. Thank you.
Thank you all so much. I am walking out of this with the following words written down for COVID and vulnerable populations: evidence, partnership, listening, trust, and respect. I think those are sort of the themes that I've heard from all of you today. Thank you so much for your contributions, your research, and sharing it all with us today. And thank you all for coming and listening.